बस वो लिंक से एंटर कर जाइए सर.
Yes.
Yes, thank you. I'm there.
Okay. Welcome, Dipanjan sir. Welcome. Good evening.
Good evening. Is my video visible or still not? I think so. No.
No,
Okay,
no,
just
sir.
a minute. I'll get my videos up and running.
Okay, so guys, we are going live at 6 o'clock, and we have up till now 46 participants watching us on Zoom, and we will be going live on Facebook as well. So wish you all the best. So yes, we are now live. So hello everyone. I am Rahul. I am the co-founder at Poornima University, Jaipur. Poornima University was founded in year 2012 in the state of Rajasthan. And I take this opportunity to welcome all our esteemed panelists for this webinar on Endgame of Tobacco, Protecting Next Generation. So I would like to introduce Dr. Anil, Mr. Anil. I'm sharing a screen. So Dr. Anil is the founder and CEO of JSPH. Anil has over 30 years of experience in establishing and running HIV/AIDS program in Africa, Asia Pacific, North America, and West Indies. He sits on various boards, including stem cell IVF programs, technology companies, and academic centers. He has worked at Harvard Medical School, WHO, and US government's Department of Health and Human Services, among other institutions. He has been recipient of grants from Bill and Melinda Gates Foundation, Tata Trusts, World AIDS Foundation, among other agencies. So Anil sir, now I request you to please take the webinar forward.
Thank you, Rahul. Good evening, India. Good afternoon, England. Good morning, America. It's a privilege to be on this webinar today. I thank Rahul, Mr. Singhi, his father, who has founded this Poornima University, and our School of Public Health is housed at Poornima University since the last year. Rahul has been a big help in helping us establish the School of Public Health, and he is an architect by training. He's the co-founder with his father of the Poornima University. They're both architects. Rahul's interest includes helping, empowering unprivileged children, women, and he likes to look into more and more new technology, digital health, and promote education around the country. So thank you, Rahul. Thanks for having us.
Most welcome, sir.
And I'd like to introduce you to the Jodhpur School of Public Health and give you a brief history of the Jodhpur School of Public Health. I have been trained and educated in the United States from my undergraduate years at Northeastern University, Harvard University, and Medical College of Ohio. My friends and I used to come to India, Africa, to learn public health. And I always wondered why we do not have schools of public health in India, except the School of Hygiene and Tropical Medicine in Calcutta, where Dipanjan did his MD after doing his MBBS from AFMC. I was driving with my former boss, who was a countess, We were working on a Bill and Melinda Gates Foundation project in rural Rajasthan. While driving, I told her 1.3 billion population in India, no schools of public health. She said, why don't we start? So that's how it started. But then I left the organization, and Dr. Arvind Mathur and I was sitting around 1:30 in the morning. That's normally I meet him at the time at the Antiretroviral Clinic in Jodhpur. And we decided to start the School of Public Health without any funding, just by tuition. And we started with 3 students. And today we are so excited and honored to say that we have conferred more than 500 MPH degrees in partnership with the various universities, including Maulana Azad University in Jodhpur. And again, I'm sure Poornima University will be helping us a lot with this. So this is the story of Jodhpur School of Public Health. And in these unprecedented times, public health has become a major topic. And I think people who did not know, who did not support public health, are supporting public health institutes. And in a country like India with COVID-19 and these pandemics, outbreaks coming up, we will need more and more public health professionals and schools. So this is the little story of the School of Public Health. I thought I'll bring it to you. And I'm happy to announce that we would be starting at a 3rd institute very soon in India. And our faculty mostly comes from all over the globe. And I'm hoping these panelists and people who are viewing would definitely contribute to this School of Public Health. I would like to thank again everybody, and I would like to introduce the panelists, if I can. So I would go with the pictures I have in front of you, and that was our deal yesterday. Dr. Puneet Parikh, he's a radiation oncologist at the All India Institute of Medical Sciences in Jodhpur. He is very much interested in telemedicine. He's helping the institute right now set up telemedicine programs. He has also been working on neurosciences. He has been a scholar at National Institute of Mental Health and Neuroscience in India. And we have been involved with All India Institute of Medical Sciences for the last couple of years. Dr. Manu Mathur, by training, he's a dentist, and he's an additional professor at Public Health Foundation of India. And we have worked together on a couple of projects, and he has been very helpful to Jodhpur School of Public Health, and he's also on our visiting faculty. Currently, he is based in Liverpool, England. And welcome, Manu. Thanks for accepting the invitation. Dr. Sitesh Roy, he's the founder of Dr. Roy's Health Solutions. It's a multi-specialty clinic in Bandra, Mumbai. He believes in holistic medicine. He was trained in India and did his pediatric residency at University of Illinois in Chicago. And he sees a lot of COVID-19 patients, and he would touch upon the COVID-19, which is the current pandemic, and everybody would like to hear that. Kishore Santla, based in England, he's the co-founder and CEO of Solutions for Health. I have worked with Kishore in the past. Leena, his wife, and Kishore, they do fantastic work. He was a recipient of the best CEO in the Artificial Intelligence magazine last year. He started as a startup. Now his company has more than 100,000 users for their own well-being and good quality of life. Welcome, Kishore. Dr. Vishwanath, he's in my area. He is at the Harvard University. He's a professor at Harvard University in the Department of Behavior and Social Sciences. He also sits on various boards, and he has helped Dana-Farber Cancer Institute for a long time, establishing many centers over there. Plus, more important, he is the director of India Harvard Health Center. Thank you, Vish. Dr. Arvind Mathur, my mentor, the School of Public Health came in the picture in between our discussions. And Dr. Mathur has retired as the principal of Medical College in Jodhpur, the Dr. S. N. Medical College. Currently, he's the director, Asian Center for Medical Education, Research and Innovation in India. his interest is geriatrics, and he has run tobacco cessation clinics. He's an expert on HIV/AIDS medicine. He's trained in India, United States, and Thailand. Welcome, Dr. Mathur. Dr. Prakash Gupta, I think he doesn't need introduction. He's the director of HILIS, Saxaria Institute of Public Health in Mumbai. He has amazingly over 300 publications in peer-reviewed journals. He is a visiting scientist at Harvard School of Public Health. And if I could continue, I could go on and on. He's a true academician with over 300 peer-reviewed publications. Thank you, Dr. Gupta. Jagdish Hirsch. Jagdish was trained in Russia as a medical doctor. He runs the Mobiloid group of companies in New Delhi, India, in Boston, and Singapore, and England. And we have worked together in the past. He has been the editor of HIV Atlas. And we started working together 20 years ago on the Bill and Melinda Gates Foundation project in Samirpur, rural Rajasthan. And now we work together in technology, and he also sits on the Jodhpur School of Public Health Board. Thank you, Jagdish. Bhavna Sati and I go back again 20 years ago. She started to work with me as a nutritionist at the HIV clinic in Jodhpur. And she also does a lot of clinical work. And today she is heading our School of Public Health in Jodhpur, and one of the few women who has been extremely helpful in motivating the young students to do School of Public Health. Dr. Pankaj Chaturvedi, the moderator, the backbone of this webinar. He's a well-known figure in public health, though he's an oncologist. He's the Deputy Director, Center for Cancer Epidemiology at Tata Memorial Hospital. He's also professor and head of head and neck surgery. And I met him 8 years ago at the Godrej meeting, and I was so impressed by him. I keep on reading about his blogs, his work he does on a day-to-day basis. I just could not believe, after all his clinical duties, a couple of nights ago, he was working with me around midnight. And again, the next morning was up at 5. So these are the people we need in public health, who are clinicians and who will take the public health forward to improve the daily living of human beings. Thank you, Dr. Chaturvedi. Dr. Rati Godrej and I met 20 years ago at the World Economic Forum during HIV/AIDS pandemic, which is all going on. And I was at the World Economic Forum, and we got together and we started discussing about the World AIDS Foundation, the workplace intervention. And she has served as my advisor, not officially on the School of Public Health, but we have been talking. She's been advising me a lot, including this webinar. She has worked at the US Consulate as a medical advisor in Mumbai. She's a member of Harvard Chan India Health Center in Mumbai. She is also on the Executive Council of Public Health Foundation of India. We do a lot of work together, and she is a big help in running my School of Public Health as a mentor, and love to have Rati on this panel. Thank you, Rati. Dr. Dipanjan Roy, he has been working very hard last few weeks with the government of India right now. He is a global health physician. He has worked in East Timor and Afghanistan. He teaches at School of Public Health in Jodhpur and Jaipur. And he is very hardworking. Earlier, he used to run institutes for postgraduate medical students around the country. And I have known him since I was in Chennai working at the Tambaram Hospital, running a HIV fellowship through the University of Washington. And he was at CDC in New Delhi. He's done amazing work in the CDC. And welcome, Dipanjan. I have introduced everybody, so we don't have to wait until I introduce the Honorable Vice Chancellor. Can we go forward with the panel now? I would like to hand over to Dr. Chaturvedi.
Perfect. Thank you, Anil. And that was a very nice introduction. And now I'm impressed to lead a group of panelists who are so, impressive background. And now you are making me nervous, actually. And Rahul, I'm so happy that you and your father did such phenomenal work to establish the university, and most important, give importance to public health, which is usually not the case for many universities because they don't think it's a priority. But I and Rati, who is my co-moderator, we will be having certain questions. We will be presenting those questions to you, and then I seek your response and try to be brief. In case somebody wants to add some more points to whatever already been said, just raise your hands and we will be able to see you and bring you in. And Rahul will also be looking at the chat box. The reason is that we want to be very interactive. So I'm requesting all the audience to put their questions in the chat box. Rahul will be collating those chat box questions, and we will ensure that all the questions coming out from the chat box are answered. And we will certainly try to make it as interactive as possible. Rati, you want to say something? Can we go ahead, Rati?
Yes, absolutely. Please start.
So let me set the theme that tobacco is the only consumer product in the world which is designed exclusively to kill. And this is the only consumer product in the world which remains profitable with a graphic warning on the packet and an admission by the industry itself that it causes cancer. And why I say it remains profitable is because today also, if you have to look for the best stocks, people look for ITC, which is India's leading cigarette manufacturer. And also very important to understand that today we are passing through the COVID pandemic. Until now, unfortunately, 6,000 Indians have lost their life. We all pay our condolences to those who have lost their life. There are families who are suffering. We want to have good wishes to them. But what is most important to understand that tobacco kills 13.5 lakh people every year. And in this century, if we do not control tobacco, 1 billion people will die in this world. So that is the enormity of the problem that we are facing with. And if you look at the Indian scenario, it is a little different from what would happen in the different parts of the world. In India, we have around 30% of our adults who are using tobacco. That means every third Indian is using tobacco. And we know that tobacco kills every 1/3 user. So if there are 27 crore people who are using tobacco, we are talking about how many lives if 1/3 of them are going to die prematurely. And what happens if you look at the micro level, of these 30%, only 10% are smokers. And of those smokers, majority are BD smokers. They are not cigarette smokers. And around 20% are those who chew tobacco. Now, any of us, we know that we don't need law to know that tobacco is harmful. Every mother tells that tobacco is harmful, even if she is not educated. Everyone knows, tamaku word comes from tam and akhu. Tam means andhera, blind mice. Akh means there is no eye, and tam is andhera. So tamaku words come from the blind mice, and all those people who are using tobacco, they are like blind mice. But what is more important, that if you tell anyone that tobacco should be banned altogether, the first reaction is that it gives us revenue. But in 2014, Government of India commissioned a report which says that in 2014, the revenue from tobacco was 17,000 crore and loss from tobacco was 1 lakh crore. That means all this logic of revenue and everything is rubbish. Basically, this industry knows that once people are addicted, even if you tell them through graphic warning, cinema hall warning, taxation, they are not able to quit. And that is why in India, the quit rate is less than 5%. And those 5% people who quit, they quit after getting the fatal illnesses. So the issue in front of is that, okay, people are not able to quit. We will discuss more about it. How do we really play the end game? And the end game is that we have to stop initiation. We have to protect our children from use of tobacco. Unfortunately, while we are working on protecting the youth from tobacco, they are the target of tobacco industry. If you look at the entire marketing tactics of the tobacco industry, the industry is much smarter than us, and they target children, and that is why the age of initiation in India is 17 years. So ladies and gentlemen, we are going to discuss how do we play the end game and how do we protect our future generation, because a society cannot be called civilized if it cannot protect its young ones. We are not a civilized society if we are not able to protect our children, and therefore we all have to come together and see how we can in next 1 hour discuss the whole issue of protecting the future generation. And then I would urge Rahul and Anilji that it should not be at the 7:20 p.m. there is an end of webinar. In fact, it should be beginning, and that is what I will expect Dipanjan, that we have to start a movement at the end of the entire webinar rather than calling it at an end and saying goodbye to everyone. So I request my co-host, my co-moderator Rati, to start the whole question answer session, and she and I will be alternating asking questions, and certainly we are looking forward to an interactive panel discussion.
Wonderful. Thank you. Welcome to all of you. We're really pleased that you could all join us for this extremely important discussion today. We are going to start with Dr. Prakash Gupta to discuss, first of all, the vast amount of data that you've collected over 40 years with over 300 publications showing the impact that tobacco, smoking and smokeless has on the individual, the society, the economics. And yet after almost 40 years, are we that much closer to the end game of tobacco? So I'd like your thoughts on that. And if not, why are we not so much more further ahead than we should be, since it is a huge burden on society?
Thank you very much, Rati, for your question. Yes, we are nowhere very close to the end game. In fact, we have just started talking about it very recently, although the epidemic is about 60, 70 years old. The reason, we can look at it two ways. We can look at within ourselves and we can look at outside. Outside is always very easy to look. Inside is a bit more difficult. So let me look at inside amongst ourselves. What could be the reason that the epidemic has grown so much? Let us compare the two epidemics. We are right now going through a huge epidemic of COVID all over the world. And we are going also through an epidemic of tobacco. Now, in COVID, you see the case fatality rate globally is about 6%, and in India it is about 3%. As Dr. Chaturvedi already pointed out, if you just take smoking, the case fatality rate among smokers is 50%. The hospitalization rate is quite high, even compared to COVID. The rate at which smokers go into ICU would be much higher than the COVID patients requiring ventilators, about which we are worried. So where is it that we have really not been able to project smoking and tobacco epidemic like COVID epidemic? The reason is the time interval between the infection, in this case picking up smoking, and the ultimate result. In COVID, it is just a couple of weeks, so we don't have to explain anything. In smoking, it goes into decades, 20 years, 30 years, 40 years. And the industry and everybody has utilized this to confuse and to procrastinate. I remember right from the beginning, the argument from the industry in 60s and 70s that it is merely a statistical association, not a cause and effect. And then, of course, they kept on with everything, with all the 7, very vivid image of 7 CEOs of the industry before the Senate, US Senate, holding their hands and Solomon oath that nicotine is not addictive. So they have gone on and on, but we in health have not been able to project our case very efficiently. And the industry, and the other side is the industry that has used every opportunity to block and delay everything that public health wants to do. So that is why the end game has been delayed. Hopefully, we have started working on the end game. We have started thinking about it now, and hopefully, we will go fast now very soon. And this particular webinar, as Pankaj has already said, would help a great deal in that direction. Thank you.
So thank you so much, Dr. Gupta. And very nicely you said that how comparison can be done with COVID, that COVID has the case fatality rate of 3%. And in New York, it may have higher, but in India, the case fatality rate is less than 5%. And Anil, I would like to direct this question to you, that here we are talking about a product which has got case fatality rate of 50%, and at most it has got 30%. And we have failed to convince the government. And here is a case fatality rate of 3%. And here we are having lockdown, and we are having everyone inside their house. Where is the failure on our part, and how do we learn from COVID era to fight tobacco, which is a bigger menace?
Thank you, Dr. Chaturvedi. I think here comes the role of public health. Whether it's companies or the governments, we need more and more training programs for corporates. We need training programs for the governments, for the ministries and public health. I've always been voiced at the Gates Foundation and other donor agencies when people like Mr. Bill Gates comes to India or other benefactors, they need to convince to set up public health programs. They need to talk to the Prime Minister that India needs a Ministry of Public Health. Otherwise, this will not even go forward. And I think that's something I would like to say that will solve most of the problems, not all, but most of the problems.
I completely agree. So now, while we are talking about that, how public health can help us in fighting this epidemic, Vish, this question is for you, that why we have failed to communicate effectively with the target population to reduce tobacco use, while the industry has succeeded, though they may not be smarter than us, but they have succeeded to recruit new consumers every year. So where is the failure on part of the public health community?
Yeah, thank you for number one. Thank you for having me. Dr. Chaturvedi, I would frame it somewhat differently. I'm a glasses half full kind of a guy, not a glasses half empty kind of a guy. So if you go back and look at the statistics and the data, there have been tremendous contributions by cancer control researchers and advocates and policymakers in actually affecting the curve, the trajectory of the tobacco epidemic. Some of them are on this panel. So I'm actually, what my argument is that it's not a failure. I wouldn't frame it as a failure. I would frame it as a partial success, but a differential success, right? So not every child we know is going out and smoking or consuming tobacco. So the question we have to understand is, why is it that we have been successful with some groups of children and are not being successful with other groups of children, I think. So that is the question. I think from a communication, public health communication perspective and public health policy and practice perspective, it's really this kind of a customization strategy that we should be focusing on. Which groups of children are more difficult to reach or are not being reached by us compared to other groups of children? And what are the strategies that we have not been using compared to what the strategies the tobacco industry has been using? The tobacco industry is, number one, very agile, right? There are always a couple of steps ahead of us. Number two, they're much more proactive, much more aggressive, much more wealthy. And they are, what they have done with this agility and this wealth is to always circumvent the tobacco control policies that we are putting in place. And that question is, how do we tackle that? How do we remain more active, more aggressive, more proactive in really countering those efforts? I think, that's where, including you, Dr. Gupta, Dr. Godrej, a number of you here made tremendous contributions to this, is really attacking them constantly, keeping them on their toes. It's not that they will disappear, but if, I don't think we should be pessimistic compared to what happened in the last 5, 10, 15, 20 years ago. I think we have been able to make progress. I think we have been able to really counter them. The question is, really trying to understand what those strategies they are using and customizing our strategies and countering them constantly. I think. So we have success stories. We can replicate those success stories in this case. The last point I want to say, given the time limits we have, is we have to be much more participatory. I think a lot of tobacco communications and public arena discussion is always about wagging the finger. Thou shall not smoke. I think, it's not going to work. There's a tobacco fatigue out there. We have to make it much more participatory, trying to understand the conditions and the reasons for which people are picking up this habit and really involve them, engage them, especially children. The most successful campaigns against tobacco with children are campaigns which engage children or took ideas from children and youth and used them to come to reach out to them.
Yeah. Great.
Dr. Parekh? Is he here? Okay. Oh, okay. Dr. Parekh, I have a question for you as a radiation oncologist. You have patients coming to you who already have the disease, and very often a very aggressive disease which needs treatment with surgery, radiation, chemotherapy, and even then the prognosis is sometimes bleak. Having seen so many of these patients, what are your thoughts on how we can approach tobacco control, tobacco cessation in a better way? What have you heard from your patients, which would be important for us to take forward as we strategize how to rethink how we communicate with people who are smoking?
Yeah. So to set up the department in AIIMS Jodhpur, we had to invest almost 45 to 50 crores of Indian rupees in the Department of Radiation Oncology. And most of the time when we are sitting over there, 90% patients who are walking in, whether they are head and neck patients or esophagus or cancer of bladder, we know that it is tobacco which caused it. And it's always painful. And then people glamorize it, that there is an advanced equipment available in AIIMS Jodhpur and blah, 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 and people doing great surgeries and great radiation. It's like something which could have been solved very easily by educational efforts, by preventive efforts and strict rules of government. We are trying to solve things. The problems of the society are being solved unnecessarily by doctors. If always it's coming in the back of mind, what are we doing? What are we doing? And then when patients and families pay regards to us, it's always we are thinking, wish it would have not happened at all. What is this glamorous oncologist and all? But we are just trying to sort out things which could have been sorted out by the educational efforts in schools, by a stricter rule by the governments. So quickly I will share, if you allow me, I will share a few of my more thoughts which I have written and which we are offered. Dr. Jeevan was also there, my friend. Okay, so I will carry on. So let me tell you, Rajasthan is a predominantly quite a sort of like scanty populated, but people are considered quite polite and many are following some religion. Some are Hindu, some are Muslim, whatever. But this tobacco seems to penetrate everywhere. So we have Hindus coming to OPD who don't even eat pyaz, the onion, and they don't drink alcohol. But all of them are chewing tobacco. We have the temples where the priests are smoking cigarettes and bidis, but they are priests. We have even doctors who are smoking cigarettes, and they are sometimes very good doctors in their fields. So it looks to me like it has penetrated so deeply in the culture, and kids who are growing up, they are observing it in a very acceptable way. And For example, in Udaipur, there is a medical college, and the garden of the medical college, there are displays that it is maintained by Miraj, the group which manufactures tobacco in Rajasthan. So that is the level of acceptance in the society that they won't drink alcohol, they won't eat onions, but they will chew tobacco. So that is what looks very dangerous to me. That, and sometimes then we read about the quit rates, 5%, 10%, even counseling. We try to do some research work with some factories to make them tobacco free. But whenever doing literature review and trying it out, the methods are what? Knowledge, awareness, counseling. For smokeless tobacco, even nicotine chewing gums don't help much. They have evidence in smoked tobacco, but not much in smokeless. But whatever it is, it looks so frustrating. So it cannot be dealt at the level of quits. No, it has to be dealt at the level of prevention. That is very clear to me in all my these years in oncology now, that no, it's not people's fault. They are getting exposed due to lethargy of government, due to industrial cleverness. Just quickly, I won't take much time. During lockdown, I was observing this news channel Aaj Tak, which we are observing what is happening in Delhi and what number of counts and cases. And there were advertisements of pan masala. No, so government, it was a lockdown. Even essential kirana stores, the grocery stores were closed. There was an advertisement going on for tobacco. And then frequently I am uploading these advertisement copies to Advertising Standard Council of India. There's an online website where you can complain. And surprisingly, they take almost 1 to 2 months to react. They have stages. We have received it. We are acting on it. We are forwarding it. So that's how it went. I even submitted on PM grievance portal that you have a lockdown, but you are motivating people to buy pan masala by allowing that ad go live on a news channel which people are watching. So that is a level of ignorance all these society and government people are having. They're accepting it, and they're doing hypocritic thing of, for example, this ban of gutka. It has mattered nothing. Gutka means tobacco plus flavored things. So tobacco plus flavor is gutka. The government banned gutka, but people are buying now tobacco alone and mixing their own flavored things. Mattered nothing. And tobacco, like all these were available in the market in black and everything during this time. So these are few of my thoughts. It's very painful. Our workload as oncologists can reduce dramatically if we, and see, one more thing. My child studies in class 8. He is going through CBSE board. It's just because in our family, we have discussed so much, they identify whenever they say ad, Papa, see, that bad advertisement is there. Even like these Bollywood stars, Ajay Devgan, Kesari Jeevan Kesari, he will play an ad of Ilaichi, but everybody knows that it is actually subtle ad of tobacco. So all these things my kids know because we have created an environment in our home like that. But at the same time, there is nothing in the books. Teachers are talking about mathematics, arithmetic, science, solar system. There are 9 planets.
Yeah. So
gradually people are talking about yoga, but people are not talking about tobacco. Sorry.
So Pratik, I can see the passion and I can see the energy, and I like it.
Yes.
I like it. And that is how we are going to win the battle. We need that energy and we need that passion. And now is the time for Rahul to come up with certain questions from the chat.
Dr. Pankaj, we have one question from one of our students of Masters of Public Health, Dr. Walid. He has asked that, is it still safe to start or continue to use nicotine replacement therapy and other stop smoking medications?
So I think quickly, having nicotine replacement without medical supervision and behavioral counseling is not a good idea. Basically, there is a step ladder pattern, and I think I can talk to Manu. Manu, the question can be answered by you, that can people just go and buy the nicotine gums from the Kirana shop and start using it for quitting tobacco? You have to unmute yourself, Manu.
Yeah, thank you, Dr. Chaturvedi. Nicotine gums as such can be bought just off the counter, but the problem with that is you don't know the exact way of taking it. And I'd like to explain this with an example. When I was a student like Dr. Wajid, somebody, we all read about these cessation practices in the book. And one of our tutors came to us and said that, have you ever tried nicotine gum? Have you ever tasted it? You say that this is given as a nicotine replacement therapy. So, and he made us taste that. There is a way in which nicotine gum has to be taken in, has to be ingested, has to be parked in your oral cavity. And for that, you need help. So, although you can buy it, you can go to any chemist, you can buy it across the counter, but the precise way of taking it, there is a tapering manner. You have to reduce the dosage every week. It cannot be taken as a replacement. So, there is a way in which you have to take this.
And also, Manu, we know that the world over, it has been shown that nicotine replacement therapy is helpful only when it is aided with the behavioral intervention.
Exactly.
Stand-alone nicotine replacement therapy is not going to help. And
It's
one
not going to
question that has repeatedly come in the chat box is that even the non-tobacco users get cancer. So why are you talking about tobacco causing cancer when others are having it? So my dear friend, it is a statistical risk that every tobacco user is having, that every third tobacco user dies prematurely. Who are the two who are not going to die? We do not know at this point. And who is the third? We do not know. So if people want to take a product which has got 30% risk of dying, they are free to do it. But unfortunately, what happens that this statistics that people were using tobacco, they lived a life and they died a peaceful death is not correct, because we know that tobacco users, they die at least 8 to 10 years earlier. So Dr. Gupta, here I would like you to come in and tell that how in your study you shown that the productive years of life are lost for tobacco users.
Yeah, Pankaj, that's an extremely important point for India, that in the Western countries, high-income countries, at least half of the death, about half of the deaths because of tobacco occur in older ages, when people are quite old, it's more than 70 years old. But in India, because of the age pyramid also, and because of the way the habit is practiced, addiction is there, a very large proportion of deaths occur during productive years. We have estimated, in fact, the production loss and a productivity loss because of tobacco also in India, and it is quite considerable. So, stopping smoking or any kind of tobacco use is a very important strategy for those who are using tobacco in any form. And one has to remember that these are just the nicotine replacement therapy and other products are just helping in cessation. They are not there to continue with the addiction, and they are not marketed for that. So there is no question that one can continue with the addiction with those products and remain healthy and happy.
Correct. And also 90% of the oral cancers are caused by tobacco. Now 10% are not caused by tobacco. They are caused by human papilloma virus. They are caused by alcohol. There are many other etiologies. Similarly, lung cancer, they can be caused by many other factors, but around half of them are caused by the tobacco, smoking. Now, Arvind, I'm coming to you that in India, we have a very unique problem, as Puneet very rightly said, is about chewing tobacco, about pan masala, about all these indigenous forms, like in Maharashtra, we have kharra. So how do you perceive and how do you think that despite so much of education and awareness, people are still sticking to this habit?
Yeah, exactly. Smokeless tobacco use in our part of the world is a real major challenge to all of us. You find that this particular type of product is posing a different challenge than smoking itself. Because of its availability, which is there, that is one important thing. And then along with this, there have been various other issues which makes this product being used more by the younger generation and the women also. So that is one important thing, that when we are trying to address the younger generation, we will have to think of smokeless tobacco as the main problem. And the problem is that there is no taboo associated with the use of smokeless tobacco. because we find that this tobacco, this particular product could be obtained anywhere by anyone. Even young school children, they can purchase it. There is no taboo. They can use it with their convenience also. And in many of these products, the tobacco is given in disguise instead of marketing it as a tobacco product. So smokeless tobacco is a major challenge for all of us. And there is one misconception which is there, that it is not going to cause more harm than the smoking, which is really a misconception, because we have seen that smokeless tobacco causes major health problems. Particularly, we have observed, besides the oral cancer and the dental issues which arise with them, and the addiction is also common with them, the problems in women is about the pregnancy outcomes also. That is one major problem. We have seen anemia in them because of the problems related to iron or B12 deficiency in them. Even cardiovascular disease risk is also quite high, because in one of our studies we did show that arterial stiffness increases even with the use of smokeless tobacco. So smokeless tobacco remains a major problem for all of us, because again, the cessation is going to be difficult for this also. I'll just like to put one particular point, that there is an important role of a primary care health provider, because they have the key position to enforce tobacco cessation and also educate people about not initiating tobacco use also. Because as you mentioned, that drugs will not be useful, the behavioral modification is most important thing. And what I have realized, that particularly in our setting, the health related education, when it comes from the primary care provider, it has a more impact than anybody else telling them about this. So all along my career, we have been always insisting on all doctors to at least address this particular issue by asking at least one question about tobacco use to their all clients, for whatever reason they have come to the hospital or to the healthcare facility, and also tell them about the problems related with this. So I feel that smokeless tobacco, because of its different formulations which are there with different names and the way in which they are being advertised, that is causing a problem, and they are targeting children particularly, because of by having a sweet agents or having a flavored agents, they are trying to target the youth for the use of smokeless tobacco. So that is the problem with which I feel that we have to address. When you look at the use of tobacco in women, we found that almost 70% were using smokeless tobacco as compared to the men who are at least having 50% of the use. And in them also, majority felt that it is not going to cause harm to them. That is the problem. Almost 30% knew that it is going to cause some trouble to them. The majority felt that it is harmless, basically. So there is a need for education at the level of the society, and also an intervention by the primary care providers, because I feel that they have a major role to help in this public health emergency, because they will have to address this particular issue. So that is what I feel about the smokeless tobacco. I think one has to create an awareness about its harm itself, and the availability of these products have also to be checked by some regulations which have been tried in the state.
So
Thank you.
Arvind, it's very interesting that you're also focusing on why we need to address this in children, because there are millions of children who are probably getting addicted at a very young age. And I think Dr. Parikh also mentioned that we need to address this with children. So that brings me to a question for Bhavna. How do you think we can take this message into schools, working with teachers and principals and possibly even peer group, to try and make it more effective, so we restrict the number of people or decrease the number of people who start using either smoking or smokeless tobacco, because we do know that most people who are addicted have started when they were teenagers or adolescents. How do we try and stop that to reach our end game?
Question is really relevant when we talking about the change as far as future generation is concerned. So we know that teachers are a crucial. They have crucial impact as far as somebody's life is concerned. It is relevant. This is relevant to be at all levels of education, right from pre-primary to higher levels. Can be engaged as the teachers can be engaged as a role model, a knowledge provider, can be trainers, they can be curriculum or training module developers. So now these are three roles where we can use these teachers and make this our goal more effective as compared to other gatekeepers. As a role models, now I think there is a need of training of trainers or training of teachers program first. Why? Because we have seen multiple studies, and many of them are done by Dr. Gupta. They are showing that approximately 50% of our teachers are tobacco users. That's conclusive study, and now how we are going to use these teachers as far as association or prevention is concerned. Again, I would like to quote Gupta's one study where it's a CAP study where he has done comparison between two states of India, Maharashtra and Bihar, and he has observed that approximately 78% of Bihar teachers from Bihar, they were tobacco users, whereas Maharashtra was only 23%. The reason their teachers were giving some kind of education and their moral science to 9th or 10th grade students in Maharashtra, and there are some strict policies as far as use of tobacco in school or school premises. That was the leading change. So I think first of all, the moment we start taking care of our future generation, we have to train these teachers. Now, when it comes to these students, so when should we begin? So, talking about the harmful effect tobacco in early stage of education can not only prevent these small kids from future indulgence, but also prevent or provide their parents to quit tobaccos. And this study I would like to mention done by Dr. Bachani. He is our faculty, visiting faculty of Jodhpur School of Public Health, done it in our district. They have observed that these kids were used to influence their parents for tobacco suggestion, and an impactful result related to behavior change was observed. So now, how we can use these kids or teachers as far as education is concerned? Now, coming to need and curriculum change at different stages, now that's really we have to change the teaching pattern, the curriculum, and make it compulsory as at all the street of education as we did for environmental science. You know that now environmental science is compulsory subject for up graduation. School level, the adolescent, most vulnerable group can be trained using real life case studies or cancer survivors cases with audio media, and we can hit them at right time. That's another important part. Here in Jodhpur School of Public Health, we are having this particular subject in epidemiology of non-communicable diseases, where we have problem-based learning approaches with real-life experiences through our three tobacco suggestion clinics, which are catering approximately the population of different category. One is our urban slums, one is city area, and one clinic is in one of the hospital known as cancer hospital, Sanchiti Hospital. So these are the three areas where we are catering our
Very good.
population.
So, Bhavna, we are so happy that you are already leading the effort, and I'm sure that our efforts will bear the fruit very soon. And we move on to the next question to Manu. Manu, you have already alluded to that. The whole game of this nicotine addiction, we know that it is one of the most addictive substance in the world. And few years back, there was a issue of lead being present in the Maggie. I don't know whether you remember that.
Yeah.
One lab in Gorakhpur said that there is a higher level of lead content in the Maggie, which does not kill anyone, did not damage anyone's kidneys, but the Maggie got banned in India. Do you remember that?
Yeah,
And
yeah,
this
yeah.
is a damn product which has got a warning on its causes cancer. You don't have to check anything. And it is so addictive that people are not able to quit. So where do you see that whole cessation technology or knowledge or chemicals or drugs have to be taken to that level?
Okay, thank you, Dr. Chaturvedi. Very interesting question, and namaskar everyone again. I, I think Dr. Chaturvedi started with it, but I would just like to highlight some statistics here. Taking Dr. Vishwanath's example, I also see glass half full. So if you compare what the progress the country has made in the decade between our first global adult tobacco survey and the second, we have done tremendously well in terms of reducing the prevalence. A place where we have been lacking is the number of quit attempts which have been made. And especially when we are talking about endgame for tobacco, it becomes even more important because the number of quit attempts have actually decreased in youngsters. And it has been decreased by about 4 to 5 percentage points. And that is something to worry about. Now, there are various reasons to it, and I would just like to allude to them a little bit. I think the first and the foremost thing is that participant by healthcare providers or the primary care providers or the auxiliaries, health auxiliaries for cessation is suboptimal in our country. We are not providing enough cessation support through our health system. Just to give you an example, about only 30% of the people who actually wanted cessation counseling were provided cessation counseling for smokeless tobacco in the latest global adult tobacco survey round. The figure was around 46% for smoking. This is a huge challenge which we have to overcome. The other challenge is that, when you're designing a cessation strategy or when you're trying to provide some kind of therapy for cessation, it is based on the nicotine content of tobacco products. And that creates a problem in our country. You mentioned about kharra. I belong to Rajasthan. I am from Rajasthan, and there are a number of cottage industry smokeless tobacco products which are available, not at all controlled. And so you are looking at products where nicotine content varies from about 1 milligram up to about 50 milligrams per intake. So how are you going to base your therapy when the nicotine content of the product used is so varied? Along with this, there are a number of larger forces to play, and this becomes very important because we are talking about sustainable development in our country. There is a normalization of tobacco use. The place from where I come from, smokeless tobacco use amongst female is a norm. You can't mix in a society when you're not consuming smokeless tobacco. There are external threats. For example, tobacco is a cash crop. It is considered to be a cash crop. However, now there are studies which have shown that it is not exactly that rewarding. There is a number of circumvention of laws by tobacco companies, and I don't need to go into the details. And then the most importantly, there are lack of opportunities to quit. As I said, nicotine content varies. The age group varies. The problem of people who want cessation support varies. So you require these tailor-made, custom-made solutions imparted through the health system or the larger developmental ecosystem to work. So it is a multi-sectoral action which is required. As you rightly said, the evidence is very clear. Therapy alone will not work. It has to be mixed up with behavioral interventions. You have to provide support to people who really want to quit, and you have to handhold them for a certain period. Nicotine replacement therapies are not the only solution. They have to be given as a drug. They have to be given as a medicine. If I don't want to use the word drug here.
Manu, I want to take the lead from where you leave and go to Kishore. And what you said, that nicotine cannot be given in the hands of the people to use it the way they want. And this is exactly what e-cigarette industry did, that they said that this is a novel technique of people quitting cigarettes, but they never wanted to place it as a drug. They wanted to be placed it as a recreational thing, as a replacement of cigarette on any kiosk where you can buy the e-cigarette and market it as a substitute of the drug and say that it helps in cessation better than the nicotine. So Kishore, because you are from UK, two questions to you. That we have a severe COVID epidemic in UK, and there are lots of deaths that are happening. That are very unfortunate, and our deepest condolences to the family who have lost their dear ones. How are you handling this entire COVID epidemic, where we know that smokers have got higher incidence of mortality because of the COVID infection, and we also know that the vapors have got higher incidence of mortality if they are COVID positive. So you are dealing with both the COVID and the consumption of smoking, and how do you use this for our benefit?
Yeah, thank you ever so much, Dr. Chetvi, and pleasure to be on the call here today. So it was good to hear that India banned the use of e-cigarettes last year in September, but you may well be aware that in the UK they are heavily promoted as an aid to quitting smoking. So it's quite rather controversial to see a huge country like India banning it, whereas places like the UK are making it more acceptable. The public health teams here are. The biggest challenge, so just as a brief background, we've probably supported in the region of around 250,000 people in helping to quit smoking, and our success rates are around 60 to 65% in terms of quit. Behavioral support is a key component of this, and we deliver it based upon a NHS NICE blueprint, and that's been quite successful in helping people to quit, and hence why we achieve the higher quit rates. You mentioned NRT, but you only talk about the use of gums. You need to provide a whole range of nicotine replacement therapy, including patches and inhalers and so forth. One of the biggest challenges in the UK is the smoking cessation programs have been successful, and the smoking prevalence has reduced from about 34% down to about 20%. So that's been extremely good in the UK. And in some areas, we've now brought it down to about 9%, and that's something to be quite proud of. However, there's huge inequality amongst different population groups. The challenge in the UK has been, since COVID-19, all face-to-face services have stopped. Yep, so you can no longer get support on a face-to-face basis or in a group session because of COVID-19. So the challenge is, how do you deliver services at scale? And this is where we've had to really innovate. Fortunately, as an organization, we heavily moved into use of artificial intelligence. We've used our 200 stop smoking advisors, data over 12 to 15 years worth of data, and then we built an AI product for smoking cessation. It's the only one globally that is currently built on AI and the evidence base. And that's been really, really important, because as soon as lockdown incurred, we then used our product, if you like, to help people deliver at scale. So we could very quickly, within days, deliver a service across the population of 1 million, 2 million people. Yep. And we found that the success rates coming out of the AI product is between 25 to 28%. And that's something that we're looking to see why it's been as good as that. It's been better than other M cessation products on the market. But the key thing here really is, how can we deliver behavioral support together with a really strong blueprint of successful delivery? I don't mean just us, I mean as a country. And how can India really benefit from that? I'm very surprised to see the low quit rates. I'm very surprised to hear, I was trying to Google the number of clinics running across India. As a company, we provide more clinics in just us than all of India combined. On a daily basis, we run 200 clinics. I don't know how many clinics I run in India. So why is it that there isn't the opportunity for people in India to quit, whether it is through specialist support, through an AI product, or through an M product, or whatever it is? There seems to be little choice. And hence, if we really want to tackle this problem, if we want to see the smoking rates in India go down from 30% down to 20%, and in some cases down 9%, there needs to be a major shift. And that's why I'm quite keen to be part of this, because I think there's a lot needs to be done.
Perfect. Completely agree. Rati?
Yes. So I think that's an excellent way for us to think about what we can do going forward for the younger generation in terms of technology, since we definitely need to be more innovative than what we've done so far in trying to decrease the number of smokers. My next question is for Jagdish, because we do want to see the number of people quit. We also want to see less people starting. But one of the key areas which is extremely important is the workplace. Do you think that we know that the workplace is safer and healthier and better for those who are smoking, as well as people who are in the environment when it's smoke free? Are there some successful models that we should try and incorporate in corporations which could be very effective in making a workplace be tobacco free?
Thanks, Rati, and thanks to Poornima University and JSPH for this excellent opportunity. Well, I have three bad news and one good news about it in terms of how we are going to go about it. So the bad news number one is, like Vish said and Dr. Parikh said, we are having a fight against the marketing machine of the tobacco manufacturers and tobacco marketing companies. Bad news number two is there is a cultural issue related to the smoke-free tobacco that people come with to the workplace. And the bad news number three is this kind of tobacco proliferates when people get their first salary or few salaries, and when they get appraisals, and when they have to mainstream into the bigger cities. So that increases. That's what I see on a day-to-day basis, in my company. The good news is every company tries to minimize the bottom line, and lower the bottom line. And now the COVID has again forced all of us entrepreneurs to cut the costs all across. And we have a huge cost because of these smoke breaks. And they always go buy one cigarette to a far off shop, and then they walk around in huge numbers. And these smoke breaks are huge productivity issue. And number two is this also takes a big toll on the facility management of the entrepreneurs. And these numbers should be thrown open for more and more MSMEs who may not be that data intensive, or may not be thinking about those productivity issues that they are having. So coming back to the workplace interventions, I strongly believe that all the workplace interventions should be centered around these three bad news, mostly, although there are many peripheral issues. But these three things, so the internal marketing to the employees should be around that area. And also it should be multilingual. A person from Odisha, normally it hits him hard, when you speak some Odia, or some language. So the message should be, the IEC material should be in his language, his or her language. So this is something which we have learned. Number two is we work with the peer groups, and that's definitely a very standard way of saying the workplace interventions. It should be working, but we really give it a lot of emphasis, because when these freshers join the jobs and they go in these small groups, and where there's one tech lead managing them, so on a day-to-day basis, whatever he does, the entire group does that. So that peer group has to be intervened there. There has to be some kind of an intervention right there. And the other part, which is the cultural part, the non-smoking tobacco, we have in our company the toilet tours. So basically, we take a lot of people from this, colleagues, to look at what they have spit there, how dirty it is, and also have a very active, situation where people can complain. These are things which, in Indian context, these complaints are not very formal, and these are left to assumption that people who would be complaining, they'll be taken care of. So these complaints should be taken care of. And I'll be quick about the encouraging part. So they should be part of the appraisal systems of the new workers, so that they have points when they have this. But most importantly, I've been talking in NASCOM meetings, is that it should also be part of the BGV, the background verification checks that these companies conduct. So, for example, a person, if there is a background verification comes to us, that whether the person is a smoker as per your best of your knowledge, it should be checked yes or no. And these kind of things may demotivate workers to some extent to at least have some kind of hold on to the job.
But Jagdish, what about companies or hospitals in the US who say they won't hire people who smoke? Do we have any models like that where people have been that clear in terms of saying that, due to managing our healthcare costs, being considerate of other people who are non-smokers. We will not hire you if you're a smoker. Are there companies doing that in India?
So, Rati, as far as I know, Johnson and Johnson and Dell India have taken some steps towards it, but largely the MSME sector, which employs most of the workers, they do not have these kind of checks in first place. They do not have this as part of the onboarding checklist, and they don't have this as the BGV. So they don't have any means to know that the person is a smoker. So very difficult to answer that.
Okay. Good. Our next question is for Sitesh. Sitesh, I have a question for you because we know that the number of young women beginning to smoke is rising all over the world, but especially in India as well. Now, we do know that, of course, they have a higher risk of cancers, lung cancer, breast cancer, bladder cancer, lung disease. They may also know that it affects their fertility, or early menopause may happen because of smoking, and all these variety of risk factors, yet we're seeing the numbers rise. So there must be something that we need to address. Are there any other social determinants in your population that you've seen that we need to address to bring those numbers down? Number of women starting to smoke, or those who are ready to make a commitment to quit?
Thank you, Rati, and thank you to the group for inviting me. There certainly are very unique features to girls and women starting to smoke, and then the maintenance of why they continue to smoke. You can call these gender-based differences that have been, as has been rightly said, the tobacco industry was very, very astute to study this very carefully about 2 decades ago, and maybe 3, and promote very strong marketing tactics focused towards girls and women, recognizing why women or girls take up smoking. As has been said, the average age of starting to smoke for a girl is about 17 and a half years, and it's usually started with another teenage friend. So clearly there is some degree of peer pressure, there is some degree of this desire to fit in, there is some degree of having this idea that the range of vitality, of being free, of being strong, of being empowered is given by smoking or by using tobacco products, which really in the teenage groups, what I see a lot of shisha, hookah, and vaping still goes on regardless of what the rules and regulations are saying, because there are many hidden and covert ways in which these are still being done. And behind this, besides the subtle marketing that is being done through movies, through social media, through messages that are being given to young girls, as I said, about freedom and independence, there is certainly other issues that can be seen, including the whole idea of women being able to earn more, the financial independence, also taking into higher positions and jobs where they have much more work pressure. When you combine that with pressures at home and caregiving stress, that becomes issues that are very unique to a woman and would not usually be seen with the male gender. Also, with regards to trauma or any kind of violence or any kind of suppressive activities that women may go through, the chances of having a woman take up or a girl take up smoking becomes higher. So in all of these factors, and there's a long list more of this that we can see, and considering that about 5,500 children are taking up smoking every day in India, and the number of women smoking in India is second only to the United States of America in terms of numbers, we clearly have a major action that we have to take. And within this, as I mentioned, first having women-centered approach. So figuring out, just as the tobacco industry did, why would a woman take up smoking? That's where each physician, I won't say this is only the role of primary care physicians. I would say that every pediatrician, every family physician, every internist, every specialist that ever had contact with a patient or with a child needs to really start talking to them before they take up the habit. The problem obviously can be addressed, has already been said, at the school level with school interventions. And I really believe that when the child is impressionable, when a girl is impressionable in those school years, she needs to be started to be spoken about. And most of the campaigns that have been geared with males in mind. They haven't been geared with women in mind or girls in mind. And looking at the unique features of hormonal changes that occur, unique features of what their mindset is, how they're trying to fit into a male dominated world, and taking up smoking in many industries. For example, in the film industry, I have patients from there who say that if they don't smoke, they don't fit in with their peers, they don't fit in with their unit that they shoot with. And that was the primary reason why they took up smoking. So we have to look at all these gender based differences and come up with very unique counseling methods, unique education methods, unique treatment methods. The other very important point that I would like to make in this section is that the tobacco industry doesn't look at men and women separately. For them, everyone is a target candidate who can be approached. The prevention methods have not looked at it that way. We have to realize that our entire education system today, the way we are training our girls and our women, is that they are starting to behave and act more like guys, more like men. And that's really what happens in the workplace, in the education industry, wherever you go. And really the stress that comes upon a girl and on women when I talk to them one-on-one, because I'm also a pediatrician, I take care of children and adolescents. And as an allergist, immunologist, I take care of adults who have asthma and have smoking as a comorbid condition, where they will lose lung function twice as fast as boys who would be smoking. It becomes very clear to me that these girls are really trying to be like the boys, because our education tells them to be like the boys. And so what we have to realize is somewhere guys are more head centered, more logic centered, and girls are more heart centered, more feeling centered. They have more emotions. And we really have to cater our education system also, our work situation also, that way for women and girls, so that they don't take on the stress that guys have been taking all these years in competition, in race, in coming up with all these ways of coping with their stress. Because girls also these days say that smoking is their way of coping with stress, coping with home, coping with family, coping with work, coping with education, coping with everything else.
So while you are from Bandra and you are looking after some of the very educated elite and smart class, you must be witnessing a lot of hookah joints and a lot of these shisha joints, and a lot of these youngsters, they hang around and just for hookah. They just there for hookah. So maybe you can quickly talk about this, how harmful is the hookah?
So there are many of these girls who come to me and say that Dr. Roy, hookah doesn't have tobacco in it, okay? Right. When in reality, they are going back to the joint again and again because they have gotten addicted to it. Now, maybe it may not have as much the level of nicotine as the other products might. And so there is a level of education and training that has to be done with them. And while the level of nicotine or tobacco content there may be a little less, the addictive properties are not any less, because there are additives, there are flavorings, there are other chemicals put in there, including things like diacetyl, which is just as bad a carcinogen as anything else. And with that, what we find is that, again, the education at the school and college level, these girls need to be told that when you go to these places, you're trying to fit in with your friends, you're trying to fit in with your peers. And that's not the way you fit in, because if that's what you have to do to keep that friend circle is not meant for you.
Perfect.
And the damage that it does is really long term.
Yeah, I understand. It is better to be friendless rather than have such friends. So, Dr. Gupta, like while we are discussing about this entire tobacco-free generation, there were questions in the chat box also that, are there any best practices world over which you are aware of, which can be the starting point of maybe at the end of the entire discussion, if we want to start one thing to be accomplished in next 1 year, perhaps Jodhpur School of Public Health can take it up.
Yeah, Pankaj, thank you very much. That's a very interesting question. And I see that there are lots of comments about educating children and starting education from schools so that children don't start smoking or tobacco use. I think Professor Vishwanath, as a communication expert, he has already told us that simply telling children not to use tobacco or not to smoke is not going to work completely. So what will work? Research has shown what is needed. What is needed is the environment, to change the environment that encourages tobacco use and smoking. And what is there in that environment? For example, the density of tobacco outlets. That itself is a big promoter of tobacco use and smoking. We already know that tobacco shops near schools, they are big promoter, they have been banned. Having a not selling tobacco products to children is an important part of the law, but most difficult to enforce. There is no enforcement drive on that. So protecting children through environment, that I think is the something that we have failed completely so far. And that is what we need to do for the next smoke-free generation, that children should not be exposed to environment that encourages smoking and tobacco use.
So Vishwanath, would you like to add to that?
Yeah, let me amplify what Dr. Gupta is saying. I can only say the environment is noxious, being engendered by the tobacco industry. Let me give you a couple of pieces of data. Tobacco industry in the US alone spends $9 billion a year. $9 billion. Every day, they spend $25 million a year in the US alone, right? This is what Dr. Gupta is referring to. If advertising is banned and restricted, what the heck are they doing? Spending all this money, right? So one of the ways to do that is on the supply side too, right? We can continue to tell the children, and we have published a couple of monographs on this, but on the supply side, we really need to think through. When I say supply side, the environmental side that Dr. Gupta is referring to, the cultural environment side, is how do we really tax the heck out of the advertising budgets, right? There are some couple of interesting studies that have come out from Harvard, which focused on not on tobacco alone, but on sugar-sweetened beverages like Coke, Pepsi, etc. And we found that if you take the tax breaks out of the advertising budget, it can have a profound impact on the demand side, right? It is these kinds of things really hitting tobacco industry very aggressively, as I said earlier, to what they are trying to do, understand the strategy, because they're extremely smart about what they do about these things. So I think we need to focus on really where do we go? How do we hit at the marketing budget, of the industry, and tax the heck out of it? Whatever, we can do a number of things. I think Dr. Gupta has said it very eloquently. We can do a number of things, but really zeroing in on this marketing budget and force them to release those data. I think, a couple of people in the US have done a great job of actually forcing them to release some of this data so we can have access to it. We need to do the same thing in India to make sure that we tackle where they are.
So Puneet, that brings a very important, what Vishwanathan said, that we have to keep pushing. And we have to keep pushing for good laws, good enforcement, good strategies. How do you see that the clinicians and the oncologists can engage themselves in advocacy towards the tobacco-free generation? Puneet, can you hear me?
Yes, sir. So there are two things I would say quickly. One is, let me just share, like here, Jeevan is the surgical oncologist, director sir Dr. Sanjeev Mishra is there, and myself, Redonk. I play double role of Redonk and Medonk. So most of the time when we were there for some preventive oncology meetings with Desert Medicine, that DMRC is there, ICMR Institute is there, Dr. Kotecha is there. Most of the time our phones are ringing for patients waiting, some procedures to be done. And we have realized that many times as an oncologist, because of the volume of patients who have already suffered, we are unable to contribute much time to the preventive oncology. So, and we are always conveying to our friends who are in School of Public Health. Pankaj Bharadwaj is there. He's not there today in this meeting. We're telling, please, 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 you keep on doing your good work. We are not getting time. We are belling the cat. We are belling the cat which was born years ago. And that's why what we can do is we can pursue all teachers, educational people, and all in a short meetings. We can't contribute too huge a chunk of time because otherwise our specialty patients start getting suffered if we are out of our OPDs and procedures. So we can be like, we have to push and motivate people who are in education sector, who are in sectors making laws, NGOs. We have to remind them again and again, please pursue this noble cause. It has to be done and it is important. But I am confessing my inability sometimes that directly to go and do as play the role of a preventive oncologist is sometimes not possible by many people.
Perfect. So Jagdish, one thing is certainly that we have to do advocacy, we have to do some efforts, we have to try to bring down the consumption. What really concerns me is people smoke at home, and we know that around 50% of our next generation is getting exposed, or people are getting exposed at home because of parental smoking. And how do you think that this crime, I think that this is a crime because your child is vulnerable and people are still smoking at home.
So,
yeah, Satish, you can also answer that. So Jagdish and Satish, both of you can take that.
Okay. So I think you bring up a very good point. Second-hand smoke, and interestingly, there's also something called third-hand smoke. Third-hand smoke is where the toxic particles go and settle in the home environment, and in combination with dust and other particles can sustain in the home environment for months and years together and continue to damage the growing child's lungs, which is the most affected, also increase the risk of inflammation, cause problems in their lung capacity, increase their risk of infections, including middle ear infections, upper respiratory tract infections, lower respiratory tract infections. As we have heard, even the COVID-19 infections are affected by the impact of smoke, and certainly secondhand smoke can contribute to that. So with all that known and recognized, and the problem actually begins from before birth, because babies who are born to mothers who are smoking are known to have smaller lungs, significantly smaller lungs, and also are known to have increased risk of wheezing respiratory diseases in the first year of life or the second year of life. And recognizing all of these factors, it becomes very, very important to counsel the parents even before the child is born, if they are smokers, for quitting. And if they can't quit, then certainly smoking outside the house and smoking not in their cars, and even telling the guests who may come home, because the parents are smokers, their guests also may be smokers, to not smoke around the child, and explaining the impact and importance of what that pediatric smoke, what that smoking does to a child and the secondhand smoke does to the child. Because one of the biggest, I think, impacts is in the first 6 months of life, where something called sudden infant death syndrome happens. And the sudden infant death syndrome risk goes up 5 times in a home that has secondhand smoke exposure, which means the parents or some other family member is smoking. So I think the quitting is a very important point that has to be put across, and certainly keeping the kids away from where they are in terms of where the smoking is happening becomes very, very important in these situations. And eventually, as these kids get a little older, they themselves become at risk because they see the adults smoking and they get kind of a silent approval that this is an okay thing to do. So if we intervene at that stage where the parents understand the damage happening to the child in different organs in the body, then they are more keen to, they may not leave it because they can get cancer, but they will definitely leave it if someone explains to them what it does to their child.
Perfect. So Rati, over to you.
Absolutely. This question is for Arvind. You know, there's a lot that children we know from girls as well as young adults who copy, role model. And there's this whole issue of how much are they influenced by others, including Bollywood films. I know there was a big controversy over John Abraham having a cigarette in his mouth for Dishoom, and this being plastered all over the buses and bus stops. What do you think an effect like that has on young people as they're watching their heroes smoking or glamorizing? And can we do something about that?
Yes, as you have mentioned correctly, this particular age, they will like to copy their role models. And today, the most influential role models are from Bollywood or so, and it is their responsibility not to advocate such products, because they will have to be serious about it, because the young children with their a malleable mind, they are going to adopt whatever is being shown to them. Herein would lie the importance of school education part also. I think we will have to address an important aspect of school education where we include these sections in their teaching itself, right from early part of the schooling, whereby the kids can develop the knowledge of not adopting all these things which are being shown to them by way of advertisements, which are luring them to use these products.
Right.
So I think there is an important role and message for those who are advocating it. They should also understand that in disguise they are being asked to promote tobacco products, as has been already been mentioned earlier, that in disguise of a simpler product, they will just try to promote a tobacco product as such.
Vish, I have a question for you. What about now most young people are influenced by social media? How have we been able to use it effectively for smoking cessation or just prevention of people from starting smoking? Has it been effective in the US?
Yeah, so this is my glass half empty side that comes in.
Okay.
I don't think, looking at the data, we have been as effective as those forces and industries that are risk producing industries that are countervailing our efforts, I think. So because here, I think most of the campaigns we have been designing are from the top down, rather than participatory, rather than engaging the kids or the children or the youth as a part of this campaign process. So if you look at where the youth are, where the young adults are, they're not on Facebook, right? They're not on the traditional media that we use. They're actually on Instagram and some other social media, Snapchat, etc. So I think that the tobacco industry has realized it. They have been very smart. The anti-vaccine groups have realized it. They're very smart and shrewd about this. I think we need to really figure out how to do this. There are a number of good experiments going on. There are a number of studies that are actually showing a lot of promise. Truth campaign is one example of that. But we are getting there. We have not been doing this with as much alacrity as the tobacco industry has been doing. So we need to really understand where the youth are. They are in certain types of social media platforms, not everything, and we really need to get there. And there are some kinds of social media platforms that are difficult, and that's where we have to work with the industry, like WhatsApp, etc., which have a different kind of API, say, compared to Facebook. So we just need to figure out and also work with the industry. I'm less optimistic, but that's what we need to do.
Absolutely. Wonderful. Thank you. Anil, I think this brings us back to you to try and see. This has been an extremely, interesting discussion from a variety of perspectives. How do we, as Pankaj said and others said, we need to take this conversation forward? How can we work with the Jodhpur School of Public Health, and what should we do going forward? What is your mission now to take this forward for Endgame Tobacco? Endgame.
Thank you, Rati.
Yes.
It's a very good question. Normally, we follow the World Health Days. So 31st May was No Tobacco Day. And because of the lockdown, these trying times, we thought best would be to get the experts like you, Pankaj, Dr. Gupta, and all of the panel members over here. We have incorporated quite a few courses, let's say incorporating HIV/AIDS in the medical curriculum, public health curriculum. We've been advocating for that. So we run a smoking cessation clinic. We also run a smoking cessation clinic in a cancer institute next door to us at Dr. Sancheti's hospital, who was trained at Tata Memorial. And we are planning to start some certificate courses on smoking cessation with corporates. We've been talking to the Economic Forum, to CII, and local industries in Jodhpur area. And Rahul and I have been talking about starting some certificate courses at Poornima University. So I think as an educational institute, as a public health institute, we could take this forward. And this is what our plan is. And as far as this group is concerned, I think it's been a fantastic panel, and we have learned a lot today. And I think we want to bring this forward. We want to have these periodic panels, periodic meetings. I personally did not expect that we will have such a good discussion. More could have been like a lecture-like series. But when Pankaj and I talked, Pankaj clearly said, we don't want lectures. And I think this has just worked out great. And we like to engage our students. I think one of the students who had a question was from Afghanistan. So I think we have a diversity of students from Middle East, from Afghanistan, from India. And interestingly, there are some Bollywood stars also, which Rati knows, she had come for our commencement once. They do get involved, and we do bring them once in a while to talk to our public health, the young professionals. We have also started the Bachelors of Public Health at Poornima University, one of the first schools in the country having bachelor's degree. And right now we only have 4 students. So there where we want to start working with these students and take this forward. But definitely corporates, we will bring them in the picture. I was reading the World Economic Report last night. Maybe Kishore could even fill us in. It is said that in the Economic Forum report for a study conducted in England, 300,000 smokers in England have stopped smoking because of COVID-19. Frankly, I have never tried smoking, but they say when someone smokes, you use your finger to the lips. And that's one of the issues with COVID-19. So 300,000 is a big number in 3 months who have stopped smoking. So I think this is something we all could learn from. And if Kishore has something, it'll be wonderful to hear from them on that.
Yeah, thank you so much for raising that. Yes, 300,000 people have quit smoking. There is another report to say there is another significant amount of people have increased the number of cigarettes they smoke due to lockdown, due to anxiety, due to mental health and stress. So it's good to see a number of people quitting as a result, but it's also concerning the number of people who have increased the use of cigarettes. So I've read both reports, and we're taking a balanced view on that information, because clearly the lockdown has had a significant impact on people's mental health, anxiety, job losses, and so forth, which has increased use of cigarettes in some cases. So I'm well aware of the article you're referring to, but it's good to see that so many people have quit smoking as well.
So Dipanjan, it is your turn now. You have been silent and you have been writing too many notes, and I'm sure you would have put up a nice report for us. So it's over to you.
Thank you so much, and good evening to all of you. It was a wonderful panelist. We are really enthralled to find all of you here, and such wonderful, enlightening discussions throughout. I don't know if I'll be able to summarize very well, because it has been all across, and very frankly speaking, I'm truly enthralled, and personally speaking, I've been part of the tobacco-free initiative for some time with the WHO. So giving that perspective, let me start with the summary. And quick thing is, thank you, Dr. Pankaj. You had made a superb scene setter with the COVID scenario, saying that 3% in India is the death rates. Globally it is about 6%, but there is 50% when you find in the tobacco users. So that's a huge thing. Only difference, maybe the time frame. It's much smaller in COVID because it's an infectious disease, has a much quick role and quick outcomes. And we are a people with limited amount of, as they say, memory. We forget very fast. So whatever you see fast is okay. Long drawn diseases are always taken care of in a different manner altogether. So what will happen tomorrow? You hear today, kal kisne dekha hai? It's all going to be today. So keeping that context, let's come back to the whole panel things. We were wonderful to understand that there is a preventive aspect of smoking. Then there is also the cessation actions which take place. So preventive aspects should start in the schools, as brought out by our esteemed panelist here, that should be starting. We themselves smokers or tobacco chewers, which make things in a completely different manner. So when you see young people see it, they are more entitled and they are more enthralled to go towards smoking and also the other forms of smokeless tobacco. Whereas when they see somebody quitting, it's much lesser because that doesn't get the fanfare. Then we are also up against a big industry. which has lots of, I was hearing the figure of $9 billion, I think, given by Vishwanath there, that they spend on things. And I remember from my days in CDC that we had something called a Camel cigarette, which was taken up. The Camel cigarette, which was marketed specifically for adolescents, because somebody did a study that if I can get you hooked onto a cigarette smoking from the age of 13 to age of 17, you become a good client for the rest of your life for me. So that was a thing, but those days the laws wasn't there, so it was put in the Camel adolescent cigarette, which was there. The people from US can corroborate what I'm saying. So given those aspects as and the tobacco industry, it is imperative that our thrust towards ending tobacco or tobacco free initiative in all forms, smoking or smokeless tobacco, whatever it is, needs to be done in a much more concerted manner. We heard much more anecdotal evidences. We found a lot of studies which have been published, etc., over the years, and that was shared by many other esteemed panelists in this. Then we also heard a very good few specific anecdotes on what is a woman and smoking, and how this young people like hookah, they want to take up the hookahs and they think that it is a different ball game altogether. It doesn't have so much of nicotine. Then we heard the nicotine cessation therapies, which also should be having a big behavioral component. But we also heard some of the good news that yes, let's not look at the glass which is half full, which we can say there are cultural issues. People take smoking like this in India. There are things like a workplace intervention. You will have to do it. Everybody smokes, your boss smokes, your everything smokes, and a cigarette in your hand, you feel like a man. That's a different concept altogether. But fact is, that's not manliness. That's not manhood. You have to take care of the fact. So that is what was greatly brought out by our panelists. So given this scenario, and there is always a hope, and without hope we cannot survive. And what is important is, let's translate and keep on going. Let's have our courses on specifics on tobacco smoking, cessations, therapy, non-communicable diseases, etc. So I won't take much time. I know we have already overshot it. I take this opportunity to thank each and every one of you once again. Thank you very much. Over to you, Dr. Chaturvedi.
So what I was saying, that now I have to give it back to Anil and Rahul to take it forward. As a moderator, my job is finished now.
Thank you very much, Pankaj and Rati. You did a wonderful job. Dipanjan, thank you so much. I know you've been working all nights on a project right now, but it was a very good summary. And we hope we would send printed summaries and I think a little report of this panel to everybody in a few weeks, I guess. And I think people at Jodhpur School of Public Health will be working on this particular report. I would like to invite Honorable Vice Chancellor, Dr. Padi, to give the closing remarks. And Dr. Padi, I'd like to introduce sorry, I think my battery is going low on the computer, sorry. I'd like to introduce Dr. Padi. He's the Vice Chancellor of Poornima University. He comes with many, many years of experience as an administrator, as an academician, and he has also worked in the American Navy, in the Indian Navy, and his network is amazing, and this is really helping the Poornima University strengthen its relationships with the government, with the industries, and with other academic institutes around the world. So over to you, Dr. Padi.
Thank you very much, Mr. Purohit, and to Rahul for giving me this opportunity to talk to the esteemed panel members of, the so senior and seasoned, the medical professionals of our country, the public health professionals. It is amazing to see you all talking, interacting, and discussing on a very, the live topic is Endgame of tobacco and protecting the next generation. We all, whether it is in education, whether it is industry, whether it is the government body, they all talk about the future of our country, and which unfortunately most of us do realize later this is one of the very important topic, and if we can protect this, if we can take care of this, it will definitely increase the future of a country value, because ultimately the children who are getting hooked into this tobacco smoking are not only losing the revenue but also losing the life. So what the panel today, I think it is one of the wonderful panel, and having connected and discussing itself is a great success, I think, because getting this kind of panel is only with the capability of Mr. Anil Purohit. It's not everybody's cup of tea to have a gathering all this kind of panel. And now it is live, and I'm very sure people will get inspiration. People will get some kind of knowledge to implement in their life, because it is a family issue. Smoking has become a family culture issue. So if they implement in their own family, then definitely many will benefit out of it. I know I was from management background. I worked approximately 21 years in one group of colleges, where every year 1,000 young girls, boys used to join, and I was the rector of the hostel. I know the moment they get placed, that day you will see everybody smoking. The moment somebody's birthday is there, then there will be a cigarette butts that the other day you will get. So even once upon a time, I know one faculty was teaching in our college, and she one day started smoking in the college itself. I did not say anything, but being a hostel rector, I could find the other day 50 girls more were smoking. Because you are the rector in the hostel, so you will come to know what is happening. So definitely it is one of the cultural issue. Definitely it is one of the family issue. People go with excitement, doesn't know the knowledge of that. And today also I was not aware of so many facts. Let me tell you, I admit. So what I can say, we have to start this education from the school level. Like somebody told, the health education should be given much better, more than the science education, much earlier than the science education. And when they come to the adulthood, I think more and more public health education should be more and more prominent, and more schools should come to have the public health, to cater to public health. More and more schools should set up with many universities to initiate this public health program, so that many more will be aware of, because it is one of the awareness program. Lacking in awareness program in India is also leading to this. So once again, I thank you, the wonderful moderator, Mr. Dr. Pankaj Chaturvedi and Dr. Rati Godrej. They have really managed well, and summarized by Dr. Dipanjan Rai, which is wonderful. And after Dipanjan speaks, and after this panel member speaks, I don't think I have anything to speak, because as it is, I am the last speaker, and so many speakers have spoken. So I personally thank Dr. Anil Purohit, Dr. Puneet Parikh, Manu Mathur, Mr. Sitesh Roy, and the other panel like Kishore Sankla, VC Vishwanath, and Jagdish Hars. They all have, and Mr. Dr. Arvind Mathur, they all have spoken so wonderfully well. It is worth watching. Let me tell you, it is like seeing a movie for 3 hours, and still you want to know something more. Once again, I thank you, everybody, from the core of my heart, bottom of my heart, and from the university. Once again, it is my privilege, being the Vice Chancellor is given to me, but I am really, really privileged to get this opportunity.
Thank you. Thank you so much.
You.
So, Anil sir, if you can just, I guess Anil sir has already left. So, because probably his battery
here.
was. Are you here?
No, I'm here. I'm here.
Okay.
Yes. Right.
So,
battery's back.
Yeah.
Yep. So, thank you very much. I think it was a wonderful panel, and as Rati had asked, where do we go from here? And as Dr. Chaturvedi at the beginning said, this is not the end game for us. This is the beginning, and we need to bring it forward, not on an annual basis on 31st May, but I think we will have periodic these kind of panels. And very interestingly, I did get some emails and calls and text messages from colleagues from my institutes where I worked in the past, and from Tata Memorial, with whom Dr. Pankaj Chaturvedi has worked, that they want to be on the panel next time. So I think we have a lot to discuss, a lot to work together, and it is a public health emergency, and we should take this forward. And as a team, we will take this forward. Actually, thank you so much.
Thank you so much.
Thank you.
Okay.